Hello, everyone. Welcome. I'm Philip James from the RFAMD podcast. And today's guest is Dr. Giovanni Mauri from Milan, Italy. He's an interventional radiologist. He's recognized by Stanford University, is top 2% scientist in the world. Dr. Mauri, welcome.
Hi, thank you. Thank you very much for the invitation. It's a pleasure to be here again.
Yeah, thank you. Last time was very enjoyable. And as always, the information that you have to share is very valuable. So thank you.
Thank to you and welcome to everyone.
This is an interesting topic today because we're talking about thyroid ablation and what we've learned the past 3 years. Why the last 3 years? Although Dr. Mauri has been doing thyroid ablation for almost 15 years, and he'll tell us more about that, there's been a rapid adoption of thyroid ablation in other countries around the world, including the United States. And it's causing some issues. So we're going to talk about the good and the bad. Dr. Mauri?
Yes, we started several years ago. The first experience in Italy were 25 years ago in the 2000, the first in human experiment. And since then, we developed this kind of techniques, then followed by Korean friends. But what happened in the last 3 years is that we saw a rapid expansion finally of these techniques throughout the world. And in the United States, with the FDA approval, this really speeded up all the process. So we are now no more those doing crazy things, strange things, but now ablation is widely recognized as a good option for patient. And this is for sure a very good thing. Now we have guidelines, we have more experience, we have more physicians offering this kind of treatment.
Yeah, it's so valuable that it is gaining broad adoption because it's giving patients an alternative to surgery and they're allowed to save their thyroid, preserve their quality of life. And you stated that in Italy, they've been doing thyroid ablation since the year 2000, almost 24 years ago.
Yes, that were the first experiments and the first proof of concepts. So the process was quite slow up to the clinical adoption. But in Italy, is almost 20 years that we are providing this kind of treatment to patients. Yes.
And the same could be said for Korea, South Korea.
Yes. In South Korea, they started. What really changed a lot has been the development of the new dedicated tool and device in 2012 from Professor Beck. Before, we were using different devices, the same for liver or kidneys, so it was not really specific. But then everything changed with the specifically designed RF ablation devices for thyroid.
So for the patients listening who have undergone thyroid ablation and saved their thyroid, we should probably send a special thanks out to Dr. Beck in South Korea for helping steer this movement.
Yeah, he has been really one of the pioneer, and he's the one providing the highest evidences and the largest number of patients. So he did an incredible job, and all the scientific community always say thanks a lot to Professor Beck for his work in thyroid ablation.
You know, I think the same could be said for Dr. Bacalvi, Dr. Spezia, yourself, for really being kind of leading the way in thyroid ablation. It saved a lot of patients from thyroidectomy.
Yeah, and not only by doing the treatment, but also what has been quite difficult at the beginning has been to provide the evidences and the proof of efficacy and safety, to collect data, to write papers, to go around the world presenting this kind of technique. So this has been also a lot of work.
Yeah, it's been a lot of work. And, you know, you look at what's happened in the last 3 years, I think everywhere, every time you look up, there's a thyroid ablation training.
Yes, in the last 2 years, a lot of trainings occurred. I'm doing training with the MITT group. Professor Spezia established a school. We are both teachers in the Savior Thyroid School,
Mm.
but everywhere in the world are showing up a lot of trainings. And
Mm.
also materials changed because now we have dedicated phantoms that are very good for the simulation of the treatment. So participants can simulate an ablation on really very good phantoms.
Yeah, we
The
can thank SurgeMate for that in Taiwan.
Yes, they did an incredible job also. Absolutely.
Hmm. Well, Dr. Maury, it's been good. I think probably if you look back, back at the last 3 years, a lot of good things about thyroid ablation. A lot of patients are avoiding surgery. There's so much excitement from doctors around the world to get trained and offer this option to patients, which is great. Any
Yes,
other good things that you're seeing happening in the
I
past three
see.
years?
Yeah, finally, there has been a larger interest also from companies to develop and improve the the devices. So we are seeing a lot of companies, for example, providing microwaves, and we are studying a lot of microwaves that seems to have some very good potential in thyroid ablation. And also we see, for example, non-thermal ablations, that there are systems now under evaluation. I'm in one of the centers that will evaluate that kind of devices that provide ablation without thermal damage. And this seems to be very, very interesting. So I see for the future a period where a lot of interesting things will happen, and maybe we can further improve the results of these treatments.
You said there's some exciting things happening in regard to microwave and non-thermal ablation. If we can pause on that for a moment, it seems as thyroid ablation started to become more broadly taught and adopted around the world. It's really been between radio frequency ablation and microwave ablation. And you could probably draw the line and say, if you're from Korea, it was radio frequency. And if you're China, it's microwave for the most part. There are some exceptions. But you're saying there's some exciting things happening with microwave. In what way?
Yes, because there are some new development on microwaves and more people using both techniques, trying to better shape which kind of patient can benefit more from microwaves and which from radio frequency, for example. It's no more a matter of you are in Korea, you will undergo radio frequency, and you are in China, you will undergo microwaves. But we are studying if that those two technologies can offer different advantages in different patients. So, for example, I can provide both techniques, also laser, and I can decide patient by patient which technique I think is better for that specific patient. This is a real advantage to being able of shaping the treatment, have a real personalized treatment to the single patient.
There's a lot of science that goes into patient selection, but let's do with this short cheat sheet for doctors listening. When to use microwave, when to use radio frequency. And we know that could be quite complex, but if you just were to break it down into the simple version.
Yes, the first thing is to use the device you are comfortable with. When you are comfortable with both devices, I prefer using, for example, microwaves for very big nodules where I want to be faster and being more sure in the time of ablation to cover a large amount of the nodules. While radiofrequency, for example, I prefer for microcarcinomas, for smaller nodules, for lymph nodes, and so on. That's to make it short. Of course, at the moment, I can use radio frequency for doing almost everything, but sometimes microwaves still have some advantage, I think.
I think every patient these days, they really have to be their own advocate. And the more I learn about the journey of a patient who's been diagnosed with a thyroid nodule, thyroid cancer, and then more importantly, who to select to treat me. I
Yes,
think to
absolutely.
go through it today, and I was ready to get ablation for a thyroid nodule, if I walked into a doctor's office and he or she had both devices, microwave and radio frequency, that's who I'm going to go with, because I know there's a certain level of thought that that professional is doing to offer me what is best for my case.
Exactly. Absolutely. That's absolutely true. And that's the same we are doing for other organs, liver, kidney, or even lung, where we also have, for example, cryoablation. The ideal setting is to have different devices and being able to choose case by case what we think is better for that specific patient.
Dr. Mauri, you've been doing thyroid ablation since 2010. How many cases have you treated?
Oh, I think more than 300,
Mm-hmm.
300 maybe more. I don't have the precise list now.
Mm-hmm. Let's put all the excitement aside for a minute about the rapid adoption of thyroid ablation in the past 3 years. What are some
Yeah,
concerns you've seen?
yes, as often happens when something start to be seen as, let's say, fashion
Mhm.
thing, a lot of physicians want to approach that technique, want to offer that to patients, and sometimes this is done without a proper learning curve. Because on one hand, for example, someone can think I'm very good in doing fine needle aspirations and doing ultrasound, so I am skilled. I can provide thermal ablation, but with no experience in thermal ablation, that is very different than fine needle aspiration. On the other hand, someone can say I'm a very skilled surgeon of the thyroid. I have no skills in ultrasound, but it doesn't matter because if anything happen, I can just open the neck and do surgery. Uh,
Mm.
Thermal ablation is very, very complex, even if when properly done is a simple technique. It is called properly image guided ablations. It means that image guidance is as important as ablation because otherwise is like driving a very fast car with a very powerful engine without, for example, the good tires. And there was a good word that was power is nothing without control. This was Pirelli that was saying that, and that's absolutely true. We need not only more power on our devices, but more physicians trained to do ultrasound and to do the procedure properly. What I see now is that too many physicians are approaching,
Mm.
and sometimes during training, I see there is not uh, enough interest on ultrasound for the guidance of the method. Everyone is interested in radio frequency, in microwaves, but proper patient selection, proper ultrasound evaluation sometimes are not enough considered. And I have some concern about that.
Are all head and neck surgeons good at guidance, at ultrasound?
Yeah, in Italy, not, for example, they are not training in doing ultrasound because generally in Italy the flow is to have a radiologist
Mm.
doing ultrasound and fine needle aspiration and surgeons performing the surgery. In other
Mm.
countries, in the United States, even radiologists are not trained for ultrasound because there are sonographers and it's
Mm.
completely different. And in Italy, there is a society of ultrasonology that is teaching ultrasound to every kind of physicians, but there's a specific training, for example, for ultrasound in the neck. You have to do the training and you receive a certificate. So it really doesn't matter the specialty, but
Mm.
physicians should be properly trained.
Mm.
Um,
How do you know if a physician is trained or is an expert in ultrasound?
Yeah, that's a very good question and is very difficult to answer because when a patient go to a physician, ask for treatment, and the physician can say, okay, you are a proper candidate for thyroid ablation. but the patient does not know about ultrasound and the importance of ultrasound, and might even not ask about experience in ultrasound, or not asking about experience in that kind of treatment. So it is very difficult. With the European Society, we are trying to develop a curriculum to provide also a certificate of to a physician that has been trained in ultrasound and ultrasound guided ablation.
Mm.
But there is not any requirement
Mm.
of any certification to provide this kind of treatment. Potentially,
Um,
with my degree, I can also do surgeries to the neck.
mm.
Is on my shoulder deciding not to go to the OR and operate on you. But once you are a physician, you are a surgeon officially. So you can do surgeries, at least in Italy, even without specialty. No one is doing that, but there's not requirement to be an ENT surgeon to perform a thyroidectomy, for example.
Mm. Okay. Now we've established ultrasound expertise is so important to getting the best treatment in regard to thyroid ablation. If a
Absolutely,
doctor
yeah.
is not skilled in ultrasound, is it something that could be learned?
Should be learned absolutely before thinking doing ablation.
How long does it take to learn?
Is not very quick. If you have a background in radiology, or for example in endocrinology, in Italy and in Europe, a lot of endocrinologists are doing
Mm.
ultrasound, it can be easier to start doing interventions. If you never did an ultrasound, I think at least 6 months or 1 year is necessary doing ultrasound of the thyroid,
Mm.
with beginning familiar with anatomy, then moving to fine needle aspirations, and you need to perform some fine needle aspirations, for example, also on small nodules or on small lymph node, and only after that to move on ultrasound guided ablations. And
Mm.
ideally, you should perform the first cases under supervision. It's not enough to attend a course and then you can start on your own patient. A lot of people is just doing that, buying a machine, saying, I'm good in doing fine needle aspiration. I
Mm.
will do my first thyroid ablation on one patient without any kind of supervision. And I'm sure that happened a lot of time.
Speaking of weekend workshops to get trained in thyroid ablation, and I'm going to share a story as a podcaster and someone who's interviewed a lot of doctors. And I've had conversations off the record with doctors. And I was told of a story where a doctor attended a weekend seminar to be trained in thyroid ablation. He went back to his home country. He selected a number of patients for thyroid ablation and, in fact, treated them.
Yes,
And there was
exactly. That's
complications. There was complications, and there was an expert doctor who who evaluated the cases of the patient selection. And this doctor had selected little tiny thyroid nodules to treat that should never be touched and put the patients in
exactly.
danger. No one's really sharing such a story publicly, but if it's happening once, it's probably happening a lot.
I'm pretty much sure that's happening to a lot of physicians attending to courses, and they are going back home trying on patients the first time. But not only there's the difficulties, the technical difficulties, but sometimes also the patient selection is not accurate. It is very clear, the patient selection for benign nodules. First of all, patient need to have symptoms. You do not have to touch a patient that have no problem from his thyroid. You can live with 1 centimeter nodules in your thyroid without any problem. You do not need any treatment. If you have symptoms, you can be treated. But too many cases had been performed on patients without symptoms just because they had a nodule and the physician wanted to treat. Also, benign nodules need to be evaluated with 2 fine needle aspirations. I know of cases of misdiagnosed cancers treated with ablation with large nodules. And also the location, for example, but that's more specific. But there are some locations that are more prone to complications that require very skilled and experienced operator. So there's a lot of things more than just sticking a needle in the neck of a patient.
So going back to my comment earlier, if I'm a patient and I'm screening at the doctor who's going to do my thyroid ablation, I'm going to walk into the office. I'm going to look for 2 devices, a microwave and a radio frequency. And now I'm going to do my due diligence and make sure that doctor is skilled in ultrasound.
Absolutely. Yes.
And how can a patient kind of vet the doctor to make sure, or where can they look to know? I mean, sometimes we just can't accept what we're told. I think the patient has to do their homework.
Yes, but it's very difficult because physicians can be very, very convincing. If they are convinced on their own that they are good in doing that treatment, and I think the vast majority of physicians are convinced of that, so they can transmit this to the patient. But too many times I saw also online new faces, never seen at any conferences, never known, just showing up like I am one of the biggest expert in this technique, and looking on, for example, PubMed, there is no publication, no conference presence, nothing before. So patients should also try to understand on the curriculum on that physician. For example, if he has any publication or conference presentation on that topic. That's something that can be done quite easily online.
There's something about peer accountability. And there is some truth to searching and seeing if the doctor goes to a lot of conferences because there is peer accountability.
Yes.
So that is one way for patients who are trying to do their own homework. Maybe they search the doctor to see if they are presenting on the topic of thyroid ablation.
Yes, or presenting their experience or publishing their experience. And when they published, if they just published 10 cases last year, it's different than if you look back at my first publication in 2012 on lymph nodes. Of course, or Professor Spiezzi or Professor Beck, for example.
Good, Dr. Mauri. Well, before we say farewell, this has been a powerful interview with you because I think it's bringing to light something that needs attention right now. Because thyroid ablation, it's been so widely adopted. It's exciting, so exciting. But I think it's also bringing to the surface some issues that aren't being openly discussed until maybe this interview.
Yeah, we need more discussion also on the more free discussion to see also the limit of this technique. And that's what you are doing, and it is very, very valuable, I think, for patients.
Dr. Mauri, any final thoughts before we say farewell?
Yeah, I want to take this opportunity also to thank you, because I asked you and RFA MD some assistance on my online presence, because I am still quite an old-fashioned physician doing my work in my office, in my hospital, and not enough online, while particularly after COVID, the online platform is the real new office of physicians, and physicians need to have more presence online. And so I think that having some professional assistance might be very, very useful. And I benefited a lot from your support with having my website, my presence on Google Maps, and assistance also on the social media. And I think that was very, very useful for me and is useful for physicians to reach the patients with the correct information, also to establish a track record of the activities of a physician, and to provide an easier access to, for example, this kind of treatments to a larger number of patients.
Dr. Mauri, thank you. And yeah, for those listening, RFAMD is really powered by a very passionate team of design and tech individuals. And if you visit rfamd.com, you'll see, if you haven't seen already, and we've extended that team is now offering help to doctors like yourself to assist with online presence, social media, and all those other things you don't have time for usually if you're a healthcare professional.
Yes, and it's time is a very big issue, and really I appreciated your passion and the passion and enthusiasm of your team in assisting us. And everything is done for the patient's benefit, because providing the correct information and good knowledge is the only key to improve the future of medicine and the good health of patients. So we are working together in that, and I really appreciate your enthusiasm.
Thank you, Dr. Mauri. And thank you for covering this topic today. It's so important what we're discussing during this interview.
Thank you very much for having me. Bye-bye.
Bye.